Welcome back. I hope you've had a chance to make some new connections with other delegates on the platform and build on existing connections. The subject of our next panel discussion is workforce retention. Employee retention within the healthcare sector is becoming increasingly tough. So how do we address this issue and boost retention? We'll look to share ideas around how to reward, motivate and retain NHS staff. We also touch upon the benefit of staff having an input into what's important to them in the workplace, always circling back to the significance of helping improve the employee experience, overall workforce experience, and of course, deliver the best patient care across the sector. To explore this subject, I'm delighted to be another expert panel. We have with us today Professor Carol Woodhams, Professor of Human Resource Management at the University of Surrey, Wendy Preston, Head of Nursing Practice at the Royal College of Nursing, and Dr. Wang, Associate Professor in Human Resource Management, Data Analytics and Interpretation at the University of Leicester. And don't forget to use the Q&A function to be included in the conversation, and you can share your thoughts on Twitter with our hashtag NHE365. Ladies, very good morning to you. How are you all? Well, I hope.
Well, thank you.
Good morning.
Good. Let's start off with Wendy, if we may. Wendy, you still practice clinically as an advanced nurse practitioner in out-of-hours primary care, so still very much, if you excuse the kind of pun, have your finger on the nation's pulse. What are the current workforce pressures for nursing?
Thank you, Helen. Yes, I'm very privileged, as well as being the head of nursing for the Royal College of Nursing, which is the nursing's professional body and largest trade union. I've also a consultant nurse within secondary care in respiratory and an advanced practitioner within the 111 setting, so very much across that primary community setting. And what I see is, all of the pressures that we talk about day in, day out as a Royal College is we're listening to our members, and that's what they're raising to us. We know we've got 40,000 vacancies in England alone. And whilst, I've heard the government, I've heard them on the telly this week talking about how there's more nurses than ever in the NHS and that there's 12,000 new nurses this year, we're not actually seeing that on the ground. And the data collection, is all very, it's very unclear and unable to pick out. We're still waiting to determine exactly where those 12,000 nurses, because our members are telling us on the ground, it's difficult. It's very unusual to go on duty, whether that be in a community setting, in a hospital, everywhere, and actually have your full complement of nursing establishment. It's very rare that you actually have the amount of staff that you should have for that particular shift.
So Wendy, how do we fix this? What would help?
Well, unfortunately, there's not one magic answer, because we know we need at least 50,000 new nurses across the UK, and they're not. That's not going to be achieved overnight. We need funding for recruitment and retention, because it's retaining the staff that we have, and making sure that people can see both the opportunities in nursing. They might be so stressed in the existing work environment, but there's so many opportunities. What we have done as a Royal College is set out some nursing workforce standards, and that gives a clear route, brings everything together across responsibility, accountability, clinical aspects, safety aspects, health and well-being, to set out what should good look like. And we've set those 14 standards.
When I noticed you were nodding all the way through Wendy's very strong opening there with a statistic that I certainly didn't realise, was the case. Just your thoughts before we dig a bit deeper into what you do.
Thank you, Helen. And Wendy is absolutely right. I'm the person always integrate the data. And I found just within 3 months, there are 39,000 nurses, close to 40,000 nurses vacancy. And this vacancy, staff shortage, has a huge pressure on staff. They dare not to take on or to use their discretion. But I was on the network. I heard nurses said, one nurse plays 3 or 4 roles. it's a disaster. It's a recipe for disaster. They just overstretched, and then it put patient safety in danger. So absolute support, and we need more data to understand, and we need to see change, which I completely agree with Wendy. We need to think about how to better utilize our current staff to retain them. That's why I offered these 4 hours to Jeremy Hunt on the parliamentary address.
Yes, and Carol, I mean, from the research you've carried out, can you give us an insight into what you think causes the turnover and also so many doctors to leave the profession?
Thank you, Helen, and thank you for inviting me onto the panel today.
You're very welcome.
So I'm not a medical practitioner, but we undertook quite a lot of research with doctors to inform the Gender Pay Gap in Medicine review that was published in 2020. And what we found is that retention is an important element to the gender pay gap. It's an important part of the gender pay gap. There are links in that a lack of retention causes gender pay gaps, and gender pay gaps can cause lack of retention. In terms of what causes turnover, we have both qualitative and quantitative evidence that there are 3 issues at play here. Really, one of them, and we can't underestimate that, goes back to what Wendy and Wen were saying about the stresses in the role. Currently, the under-resourcing of the profession that is causing every doctor to feel, especially in primary care, to feel overwhelmed, really. The second issue would be the issue of the pension cap. So a lot of doctors at senior levels, well-paid consultants, are leaving or scaling back their hours because it's becoming disproportionately, they are disproportionately worse off the more hours that they work through taxation and pension issues. So they are having to scale back in order to make sense of their employment and their work. And then finally, of course, the issues that we identified in the report, in the review, is that in the training levels, in the training structures, women in particular are struggling to make sense of how medical careers can fit with lifestyles that include family and flexibility in terms of how they can make careers work for themselves. So there are these three kind of main concerns that are causing higher turnover in the medical profession.
We'll return, hold that thought, Carol, about women and flexible working, because we'll return to that in a moment. A question that, perhaps you can tackle from Andrea. Andrea says, how is it possible that a builder earns more than a nurse? Shouldn't salaries reflect roles, responsibilities, risks and instruction degrees? Why annual increases don't cover the increase in the living? I mean, that is a real difficulty, isn't it? I've firsthand, unfortunately, how hard our nurses and our doctors work. And when you realise that some of them are then struggling to put a proper meal on the table.
Absolutely. It's, nursing is a safety critical profession. We, a newly qualified nurse, it's not actually that much further above minimum wage. They will have completed usually a 3-year degree or master's program, and will have the associated student debt because we no longer have a funded bursary for nursing. So there's all those additional considerations, never mind having to try and, struggle through the current issues we have. So, for example, one of the issues we've got at the moment with our community nurses is they have to usually use their own cars for work. So this current write-up, so we speak at the moment, one of the big issues on top of pay is the having to pay for fuel, where the usual reimbursement amounts they're just not enough to cover. So we're hearing reports of community nurses having to pay, several £100 extra per month to go and see their patients. You know, we've got such a lot of issues. It's a massive pay issue, but also those associated things like fuel, car parking charges as well.
Yeah, absolutely. When your work has been recognised nationally, your investigations, I know, are based on rigorous data set and innovative measures. And I'm fascinated with what you do. But one of your findings has been that 1 in 4 NHS staff reported personally experiencing harassment, bullying, discrimination from the public since 2017. And the situation, I gather, is worse among ethnic minority doctors and nurses. They're shocking statistics. What has NHS England done at a national level to try and address this issue?
That's absolutely, I would like to say, following Wendy, apart from pay at workplace, this is just unnecessary harassment, bullying, and discrimination from the public towards our health workers, which is completely unacceptable. And the NHS has this zero tolerance to any discrimination, bullying, but it wasn't implemented properly. And 15 hours ago, we know at Stoke Hospital, doctors experience bullying. Half of the health workers experience bullying. And I look at the 2021 NHS staff survey result. The bullying towards ethnic minority nurses and doctors and increased dramatically. And what I feel is, the Equity Act since 2010 and the Race Act since 1968, we have all the regulations and we have all the campaigns, but it didn't work. It's really, we need to hold the workplace accountable. That's why I offer these 4 Rs. We need to hold these senior leaders accountable. And related to this harassment, discrimination from nurse, from colleagues, managers, and from public, relate these numbers with senior managers' pay and their performance. And we need to respect our health worker. And many nurses told me we were called heroes, key workers. And after the pandemic, they come back again. You are rubbish, you are useless. It's heartbroken to hear they have to endure such abuse at work. When you're under stress, you're bound to make mistake, and the stress will make people take sick leave, and the doctors have to leave NHS because of stress from public. It's very interesting, my research.
Sorry.
Carol says there Carol says there nurses are leaving because we don't treat them properly at work, under toxic atmosphere if they complain, etc. I won't even start on the pay and hours work that are not paid for. Why would anybody want to be a nurse? And that begs the question, when do you think that staff feel safe to report it when they've got problems, or do they feel that they can't complain?
That's a very good question, Helen. I talked to staff. What we found out is patients were treated very well, because we always include government and NHS staff. They're very professionals and they put patients in the center of their care. So patients can raise complaints through website and through these reviews, but there's no such proper system for staff to raise complaint or to raise bullies at work. And some staff told me they can't find anywhere to raise. And also it's very difficult for them to find evidence. Like if your line manager treats you unfairly, how can you collect the evidence from your line manager? So the system was designed to support our nurses and doctors. At university, we have this zero tolerance to discrimination. We have report and support app. People can report anonymously, which we encourage bystanders, and they can report. So I think we can take advantage of this technology to support our health workers.
So, Carol, we've got a big problem here, haven't we, with retention? Touched on a little bit flexible working, and perhaps that could help keep more women retained. Can we dig a bit deeper into that side? What do we need to do to keep them happy?
Yeah, thank you for that question. Medicine and medical training is a highly regulated, standardized and credentialized system where it is important for doctors to, via exams, to reach the standards of care and quality and experience and knowledge that's expected from a doctor. So doctors face a long series of stages in their medical training. The issue about imposing flexibility on that is that, and they have tried to do this following reviews a decade ago or so, tried to make medical training more flexible. However, if you choose, for example, or for circumstances related to your personal situation, you are required to go less than full-time, is what they call part-time for doctors. If you're required to go less than full-time, then what you can find is that if you follow that system of working pattern for quite a while, you're set back. And from our research, what we showed is that the setback is disproportionate to the hours lost. So if you lose, let's say, 2 years by working at 50% for 4 years, okay, you've lost 2 years of training, you are then set back more than that. So you take a penalty that is greater than the hours lost through the lack of experience and training, the training hours. Sometimes you have to start again at the beginning. So flexibility is very good in theory, but in medical practice, it tends to have a disproportionately negative effect. And that is part of the gender pay gap because it disproportionately impacts women in relation to men.
But
So
who makes those decisions, Carol? Where is this coming from? Because it just seems to make no sense. The way you've explained it just doesn't make any sense.
Well, there's logic to it because of the deterioration in skills, I would suggest. Yeah. We have urged in the review that deaneries and the Royal Colleges look at how medical training is structured to try and investigate every decision and undertake an equalities impact assessment of every decision around where and how the penalties for time out are applied. So, is every penalty for time lost really justifiable?
Yeah, I'm sure Wendy's got something to say on that subject. Have you, Wendy?
Yeah, absolutely. It's also we see that in nursing. Also, if you have a gap and go back, often have to start back on. So you might have a nurse that's very experienced. They might, if they're in agenda for change, might say be up to band 7, even 8A. And if they either take a short break or do a slight career change and move into a different setting, often have to go back to band 5. And we also hear of organisations that won't, when you're looking at transferability, won't acknowledge things like increments. So often nurses, like other healthcare professionals, feel trapped with their career choices. And then when you've got, if they're unhappy in their current workplace, they've got life change, no work-life balance, and then they feel trapped. That's no wonder that they leave the profession. And I know from, I work very close. I work on a multi-professional rota in my advanced practice role. And my medical colleagues say exactly the same thing. It's really difficult. I work, when you've got portfolio roles, things like where I work 2 days a month in my advanced practice role. It's really difficult when you look at that wider context. It's as a part-time worker, you've not often got all the accessibility that you would do if you worked full-time.
And Wendy, what can local organisations and the integrated care systems do you think, to try and increase the nursing workforce? Presumably there's a role to be played there.
Absolutely. We've got a fantastic opportunity as the integrated care boards are set up. Please look at our nursing workforce standards. There's a lot of expertise gone into looking at, we've tackled all the tricky issues, but we've also tackle things like looking at, ensuring you have an executive level nurse, that accountability is across the whole board, ensuring that nursing workforce is on every board meeting. And I think with the integrated care systems and the new integrated care boards, there's opportunity to look across the system for recruitment, where you've got things like we really need to have more looking across systems and having portfolio roles. A lot of people have to have individual employment contracts when actually you could have, say, a specialist nurse, a consultant nurse that works across an entire ICS and really make improvements. But what we need is HR systems that work together and enable to make that happen, because it's often HR and systems and organisations think it's too difficult, so they don't look, and they're all trying to recruit their little bit rather than looking at it across a whole system.
Just briefly, Wendy, because obviously I want to move on, and Carol, but Carol from the audience says, I'm a qualified nurse SRN, for those who remember that. Paperwork took a fair amount of time. There seems to be even more of it these days. Is all of that necessary?
Yeah, absolutely. I think across all healthcare professionals, there's such a lot of paperwork, and it's about having systems in place. And I think going back to the integrated care systems, again, that's where we can try, if we, I hear all the time at a national level that we've got all these systems, that computer systems that talk to each other and work together, but actually reality on the ground, that's often not the case. When I'm in my 111 role, very rarely can I see the general practice records, can't see any of the secondary care records. If we have systems in place that work together, that will make documentation a lot better. And a lot of the time, the extra paperwork is all workarounds to make sure that we've got everything documented. And what we do know is most nurses do all that documentation when they should have finished their shift, and they're doing it in their own time and unpaid.
I think just from a personal experience, I think shorter, sharper, accurate documentation. I think there's so many notes written that then the system's so stretched, when somebody turns to somebody's notes, there are so many pages of it that they can't possibly have the time to read them. When the incidents of discrimination, I notice, are significantly different across different regions. So are there policies and procedures different regionally too?
That's a good question. I think the national regulation is the same, and NHS as a national organization is the same, but really it's down to the local management. And having said the discrimination is really bad, but we do have good news. I look at the 220 NHS trusts. In one of the trusts, there's no any discrimination incidents from inside, and for NHS trusts, there's no any discrimination incidents from public. And there are quite a lot of goodies, but there are about 55 NHS trusts has very high incidence of this discrimination. I think a lot of things need to do, but because the discrimination happens premise, so management can do a lot to intervene. That's something I call it behavior spillover. If the workplace is very supportive and manager respect each nurse and colleagues respect each other, and the public would see it, it will stop discrimination from the public. Because the insider discrimination can infest discrimination from the public. So that's something I feel local NHS can do.
Yes. Carol, what do you know about the culture of medical workforce and the cultures of trust in enabling or indeed hindering retention?
Well, that's a really good question, and thank you for asking it, because following on from the review, we've had permission from the Department of Health and Social Care to continue to use their data. And so we've used the same quantitative data sets as informed the review to do a deep dive into cultural issues in trusts. And this is quantitative rather than qualitative. So it complements really nicely what Gwen was saying. What we found is that doctors are more likely to leave when there is a predominance of white men in senior levels and in their specialty in trusts. So we looked at surgeons in particular, and we have the records, the longitudinal records of surgeons for the last 10 years. And we show that the decision to leave and actually to depart the workforce is statistically related to the proportion of white men in the consultant role, in that subspecialty, in their subspecialties and their overall trusts. So we take that as an indication, a cultural indicator of in-group and out-group status, and of how welcomed diverse workers are in a trust. So we take it as a means of closing off, of closure within the profession to people who don't fit the standard and idealized white male norm.
Gosh, that's absolutely fascinating. I had no idea about that. I mean, the things that data reveals, Carol, just extraordinary. And I know Wen will be nodding away there as well.
Yes, unfortunately, of course, departure is and I should have made this point really, is disproportionate to the proportion of people in the workplace. So it's a difficult concept to explain, but it's over and above the lack of representation of diverse groups in the workforce. They disproportionately depart, and they disproportionately are encouraged, we consider, out.
Amazing. Wendy, Carol, who was talking to us on the from the audience, just following on, says, as a student nurse, we weren't allowed to go off duty until we'd finished our report. So just a comment back there. And also Pam says, Wendy, shouldn't real workforce planning stop the silo working and recruitment? I agree with Wendy, roles should run across organisations. It's time to think outside the box. I suppose you'd agree with that, time for thinking outside the box.
Yeah, absolutely. I think, we can't, it's someone had said in the chat, when you look on the media, we can't keep saying it's all doom and gloom. It is very difficult. I've been a nurse for 33 years. It's the best career ever. And what we need to do is show the opportunities to across nursing. There's so many opportunities across, clinical area, education, research, all the various different settings. What we need to be able to do is show that and get the next generation, get those 10-year-olds and those people looking at their, what they want to do when as they're older, and also people are all, looking at changes in career, but also how to retain the nurses that we have got, because what we see is there's not an investment in helping those nurses that have come off shift, are so fed up they're going to leave the profession, and doctors and other healthcare professionals. Why don't we help them to look to see there's opportunities, and don't think as organisations we've got to keep them? Let's look across the whole integrated care system, the whole health and social care system, for a better future.
Do you agree with Wendy there?
Oh, definitely. Because this nursing career is really human relation based. There are so many things 50 plus nurses can do to make it better. For example, they can play the role, become a teacher or advisor for the patient before discharge. Then we can reduce readmission rates. Because in NHS England shows we have 15% readmission rates. Each admission costs, 15,000 pounds. That's quite a lot. So nurses, senior nurses don't have to go to the management role, but if we can give their job roles like, mental coaching, younger nurses, which can reduce turnover among younger nurses, and also they can work with patients if we give them time to sit down and with patients to plan home care before discharge. It can help to save NHS.
Carol, we're so lucky, aren't we, in Britain, that we have the NHS, and it can indeed be an incredible career. We heard Wendy talk about 33 years there in nursing. How optimistic do you feel that on the back of all this data and talking about the problems that we have within the NHS, that there will be some solutions and that retention will improve and that we'll still feel as proud as ever of our NHS?
I am optimistic. It's being taken as an issue at the very most senior levels. Both Wen and I presented a couple of weeks ago now on a select committee for Jeremy Hunt, who's looking into the issue of workforce planning and how to make the workforce more sustainable. So I am optimistic.
Good. And we'll give the final word, Wendy, to you, because we've just had a question popped in the box from Alice. How can smaller trust organisations look across the wider integrated care system for further opportunities for our staff? Where do we start? What tools are available to us? Good question, Alice.
Thank you. Well, as I mentioned earlier, the nursing workforce standards go across all settings, including those smaller organisations. And what we need to do is ensure that we've got those that nursing voice at those integrated care systems, because what we're very good at is looking across all the different settings and also looking for those smaller organisations. But I think the advice would be is know what you want and ask for it. You know, have clear nursing leaders within those organisations who will be able to look across that wider health and social care system, and don't be afraid to ask and put business cases in. I'm always been able to, you know, put business cases in and get additional resources. So don't be afraid to ask.
I knew this panel would fly by. I can't believe that 30 minutes has gone already. You've been smashing guests, and I do hope that you'll join us at a future NHE event. It's been brilliant to talk to you. Thank you very much indeed. Another great conversations, and thanks to those of you who joined me on our virtual stage and asking some questions. It is time now for another break to re-energise ahead of more great thought-provoking conversations to come. This is a perfect opportunity for you to discover our NHE 365 platform, including the digital marketplace and on-demand content, even, just putting her teeth back in, as well as the networking functions that you may have tried in our first break. So enjoy, and I'll see you for our next session at 11:35.